Good afternoon, everybody. My name is Eric Inman. This is Jeff Williams, two of the co-founders. The other co-founder is also here over there on the side, Dr. Ron Nicky. And so 3 for 3 here this year. I think it's the first year that all of us have been able to make it to the conference. So great to be back here again. It's a great venue. So last year we gave a little talk as well. This year we want to kind of give everybody an update and talk about what's happened in the last year with WellBridge Surgical in Indiana, what kind of hurdles are being put in front of us, which of them have we jumped over, which of them have we tripped on, which ones are ahead of us still. We'd like to talk about that, and then we'd love to make it pretty interactive to where as we go on, and you raise your hand if you have a question. We'd love some back and forth, and we'll try to maybe you can learn something from us, but we can learn something from you too. I heard it was pretty hard to see everybody, but I can see most of the hands. So if raise your hand, give a shout out if you have a question as we go along. We'll start off with, for those of you who weren't here last year, who haven't heard our story, we'll tell you a little bit about our story and say how we got here, and kind of go on from there. So start off with. Yeah, that's right. We'll stay with this one here for now. It all started about 6 years ago now. We came to our first Free Market Medical Association conference. I think it was in Oklahoma City that year. And we had just heard about what Dr. Keith Smith was doing at the Surgery Center of Oklahoma, and had a couple conference calls with him. I think there was phone calls back then. I didn't even know what Zoom was back then. So had some calls with them and learned about what they were doing, and got to start thinking. And he was encouraging us with, maybe we can do the same thing up in Indianapolis with the surgeons that we know. And there was a group of us together, Dr. Panicki, myself, and then also Jeff here, and got to the point where in 2021 we had our first surgery. But along the way, my background is I'm an anesthesiologist. Dr. Panicki's an anesthesiologist. We were both in Central Indiana practicing for about 8 or 9 years, and then got to about 2017, and I think both of us had gotten to the point where we had gotten comfortable doing what we were doing in the operating room, kind of looking to see what else is there to learn about within the healthcare system. Came across the payment system, which we found out a little bit more about when we were talking to Keith, learning about the self-funded employer space, and learning about really surprise bills, the way people are presented with how to pay for their health care. And as we got more and more into it, we really decided that this is something we want to do. We do not want to do a traditional surgery center model. We don't want to do fee-for-service. We want to go for the bundles. We think that's the future. And then in 2020, it took us a few years to really gather up the courage to do this. Talk to some surgeons early 2020, late 2019. We didn't really know. Going along in the operating room with a few different hospital systems, didn't really know that we were gaining vital knowledge. Sean just talked about quality. We're really seeing it right in front of us in the operating room with Dr. Panicki and myself. Which surgeons are going to make it look like a super easy surgery, very minimal complications, make it go quickly, very efficient. We got a front row seat for years to see how do you do this the best, what surgeons we want to partner with, and so gathered the troops with a lot of independent surgery groups, and then in 2020 we were probably the only ones around looking for commercial real estate around May of 2020, and so got a pretty decent deal on a building, started building, kind of gutted the building, and built out the surgery center. It took about a year or so, and in December 2021 did our first surgery, like a tennis or a golf elbow procedure, and that was the second most nervous I've ever been doing the anesthesia for that, because it was just pretty surreal being able to 4 years of planning, and actually we'd actually finally done it. And so last time we talked here, it was, we've only done procedures for a few years or for a few months, and so I want to give you an update to where we're at. But talking about quality, talking about all the surgeons we met, and trying to get the best product put forth to the consumer, to the members, to the patients. What we realized, and have realized even more in the last year or so, is that you can have the best surgery center, the best processes, the best staff, but with what we're trying to do, what I tell everybody when I'm talking to them about what my passion is changing the way patients make it to the operating room, how they get there. They're not being blindly led, or having blindfold on, being led by the PCP to the surgeon that they don't know, to a place that they don't know, in the ambulatory surgery center or hospital, not knowing the quality or the cost. To change it to where it's not the surgeon just taking the patients there, and it's creating a more consumer-based approach to healthcare. You have to have the patients there. You have to get the referrals. And how do you do that? Dr. Panicki and myself being in the operating room, being anesthesiologists, that's one part to help out. But what we needed was a business end, a business mind, a business partner. And so I'll let kind of pass it off to Jeff to talk about really what he's done and what we've learned as far as getting the referral flow to our ambulatory surgery center and get the word out.
All right. Again, my name is Jeff Williams. I think our faces are still up there, even though we're missing a slide, but let's go on to the next one. Because
it makes me self-conscious. I see the crow's feet up there. One of the surgeons the other day was talking about me getting Botox, and I'm like, no, I see it. I need some, but I'm still
So yeah, I think from my standpoint, I told my story a little bit last year, but I'm an entrepreneur. I've been a business owner for almost 20 years now. And in 2017, my insurance rates just kept a dramatic jump. I think it was 43% that we were going to be hit with. And so obviously I didn't like that idea at all. And so we had, I think it was like a $2,500 deductible back then. And so we raised it to a $5,000 deductible in order to get a like 21 or so % increase. I don't remember the exact numbers, but I mean, it was just like, okay, something's wrong here. And the next year, the same thing happened. And so that year, we had actually just come out of strategic planning. We had 3 hires that we were going to make. And then we got the news of the increase. And it was like, all right, well, I mean, we picked one of the 3 to hire. And so this whole thing, as an entrepreneur, did not taste right to me. Made no sense. The deductibles are going up, the premiums are going up, and we're not really seeing any extra benefit as the payer. And so around that same time frame, Eric and I have known each other since 4th grade. I think we were by the pool, at least that's the story that I tell, and I was razzing Eric about him being the main problem with the increases in my health insurance. And he had to pay for this pool, and so he's probably just increasing prices. And as a good friend would, he punched back and said, hey, what percentage did I make of like a surgery bill? And I said, no, I have no idea. I'm just a dumb, business owner. Just keep writing checks, into the, at that time it was Anthem and the Buca. So anyways, I started to realize, he said, it's the facility fee. And I mean, I was like shocked at the percentage that the facility fee was getting. I was like, okay, now something really doesn't make sense. And so that kind of started my journey of, hey, I can continue to complain about this as a business owner, or as a good entrepreneur should, I can just go out and be a part of the change. And so that's kind of the quick version of my story. And my passion behind this is putting more money back in the employer's bank account, right? To be able to innovate and hire and grow, which then grows the community, and putting more money also back in the employees' hands too. My employees are the ones, right now in some of my businesses, we have 80 employees, right? They're the ones out there making it happen, right? I'd like to put more money back in their pocket as well, and they can decide how they want to spend that money. And also, obviously, quality too, because I've learned so much through this process, more than I want to know, actually. probably about how surgeries work, that not all surgeons are created equal, and those sort of pieces. And so, in order to guide my employees through the plan to, higher quality, lower cost of care. So anyways, they got the crazy business guy, entrepreneur on the team as well here. And so when the construction was getting going, I was like, well, it's probably about time that I try to figure out, how on earth this whole thing works. And so a lot of people have asked me, well, how did you get started? Well, I got started with my first phone call, which was a CFO of a large ag company that I knew, and called him up and just said, hey, this is what I'm doing. He's like, you're doing what? I was like, I know, just hold on a second. And just explaining to him, what could be, and that led to another phone call. And so basically, if you have a pulse and you're a buyer in healthcare, I was having a conversation with you to try to figure out how to make this whole thing work. So last year we were here, I didn't know a lot of this. I felt like I've lived a lifetime since 12 months ago, but just want to talk about, what I ran into. I thought this is a slam dunk. I'm a business owner. We're going to be able to have higher quality of care, lower price. We're about 50% less than the market, so any good salesperson should be able to go out there and sell that, right? And Indiana, which was the slide that was supposed to be on here, 71% self-funded plans. So I've got a great audience. I've got this should be easy. But obviously, like anything, there's hurdles. And so one of the first hurdles that I ran into was politics, right? The hospital systems have donated to about everybody, I think. There's more banners on the baseball fields, and donations going out makes it, a little bit of a conundrum when you're out there. The other things with that politics is advisory board member seats on the hospitals as well. And so right out of the gate, I'm part of an organization called YPO, and I started working my YPO list too. And I had a really good target on there. I was like, I know this guy, he's gonna love this. Called him up, he sits on the board of one of the major hospital systems and wasn't gonna touch us, and still hasn't with a 10-foot pole. Like I think has already been talked about, the brokers, major hurdle in Indianapolis. We have some major national players in the market. We've got what we refer to as the brokers, and then what we refer to as the benefit advisors. They're the good ones. Luckily, there's good ones too out there. But like with the bad brokers, it's pretty hard to overcome what they're saying when you don't even know exactly what they're saying. But all of a sudden, what was a hot lead just totally goes cold, and nobody answers their phones anymore, that's for sure. So how are you supposed to exactly get back in touch with this person? So they can really throw a wrench in things for us out on the sales front. But luckily we've got a lot of good brokers too that have adopted us and are just absolutely killing it for us out there. So change, which I think was talked about in another session as well, change is really hard, and people that don't want to change will come up with the most ridiculous excuses to not change on what is an absolute slam dunk. I'm still yet to have anybody prove why WellBridge is not a slam dunk. I mean, we haven't run into it. So just heard a lot of excuses. Plan development is a huge piece of it. I know it's been talked about as well, but I'm not one to reinvent the wheel. So when Jay and Dr. Keith came up to visit, we were just waiting to get you to dinner to get all the wisdom that we could out of you. And what we call zero tier, I don't know what you guys call it, but I'm called the same thing. I think there's better branding around that. So okay, all right. Zero tier is where it's at for sure. They didn't steer us in the wrong direction, and no matter how much I preach zero tier, there's always a group that doesn't put zero tier in their plan. Instead, you're like, yeah, zero tier, and they're like, yeah, no, that sounds great. And like a month later, you realize that they wrote in their plan with their benefit advisor or their broker something that I don't even understand. And I've been a business owner for years working with these plans, and now it's all I do is basically work these plans for the last 2 years, and I still can't make heads or tails of it. And so therefore, the adoption, right, is pretty low. Zero tier, the adoption is fantastic. anything else, and the numbers just start to drop. So convincing the employer to actually do zero tiers, it can sometimes be difficult. HR directors versus CFOs. So the HR directors, that we have some folks that want to make a difference, and then we have some of the HR directors that just they fit back up in the change is hard category. And so really I try to call on the CFO. The CFO is usually numbers oriented. Eric and another TPA that we work with will do a reprice study, and those reprice studies are slam dunks for sure. When you're saving 50% on average, when you say Eric in Indianapolis area, but even more than that outside of Indianapolis, up to 60.
Yeah, often it's 60 up in Fort Wayne or a high price area. And overall, Indiana is I think fourth highest in the RAND study more recently, and then fourth lowest for the surgeon reimbursement. So.
Yep. Yeah, so I mean those are big numbers, and then we'll talk about our quality here in a second. So when you combine those two, it's just amazing. The last one I'll talk about on hurdles in Indiana, the HSA is just, and we talked about that, hasn't gotten any better. I'm trying to convince the plans to just drop the HSAs altogether, but that is a real pain point in Indiana for sure. Eric and I have worked together on that, so we do have plans and employers who have just decided that they'll take the risk. They're not worried about it, and their attorneys have told them, what the risk level is, and it's, in their opinion, it's not much, and they decided to just, even on a HSA plan, to go zero tier. And then obviously on the PPOs, it's really easy, but HSA plans are a real pain in the state of Indiana, and a definite hurdle. Is there something you're going to touch on HSAs?
So for when we're talking about HSAs and PPOs, it goes to what Jeff was saying earlier. The simpler, the better. If you don't keep it simple for the member, then they're going to get confused, and they're just going to go back to what they've been brainwashed to do over the last 30, 40 years. Is just to kind of follow the traditional system that we all. And the reason why we are all here is we know that that's a poor system. And so,
I was just going to say, for the people who don't understand, a qualified high deductible health care plan, the employer cannot pay zero out of pocket, supposedly, until they meet their minimum statutory deductible, which
Correct.
is $1,500 this year. And so there are employers who are going around behind it, incentivizing with a cash reward or doing some other things. There's some creative, or holding, going in and paying for it and seeing if the patient meets their deductible further down. There's some creative ways of working with that, but it's a big barrier for us too.
Yeah, we have some that are doing the HRA reimbursement on the deductible, so then it still equals obviously zero. There's a lot of different ways around it for sure, but it's.
But the majority, I think, are still not going around it, and it's
Right.
a big hurdle. That,
Right.
And trying to get them all to go to PPO is not the easiest.
Right, and what happens, from what Eric, you've told me at least, is that when somebody comes in and they're not zero tier and they have to pay their deductible, right, then we get a lot of cancellations based on that.
But we've had a few to where we look at the plan. Okay, this patient is in this, has this plan for that employer, in which they're going to owe, say, $1,000 or $800 or something. And to my surprise, and learning as I've learned as I go on, I still wear a lot of hats at WellBridge. One of them still is looking at what the patient's going to owe when they come in. We have them pay that up front. And so if they're faced with, okay, I'm going to owe $800 up front here, that's something that they don't have. They don't have in their bank account. They can't do it. They're going to have to cancel the surgery. And my conversation with it, we don't want that to happen, obviously. So another reason why zero tier is a great thing for the member, great thing for us, great thing for everybody. What my conversation with them, and kind of in my head, I don't say it this way, but my thought is, well, if we're going to be the better price, and so you're going to owe less here. The only reason it's a better financial decision for you to go somewhere else is if you're not planning on paying. And in our mind, if that's the case, then you should probably go to that other place. But it's something we struggle with and something that's frustrating because we want to be a haven for everybody, and just wanted to share some of the hurdles as being one of them with you all.
Let's
Go
go
to
to
the next slide.
Yeah, there we go. Sorry, we're still staring at us up there and up here. So, I mean, realistically, so I'm talking to anybody that has a pulse that is buying healthcare, right? And so in this case, I wanted to go over a quick case study of Haynes Aerospace. And so there are 1,800 lives in Kokomo, Indiana. You can kind of see from the picture up here some of the things they do, but this space program is part of it. And so they came in for a tour. That's what has won us the most business. I would guess we're batting almost 1,000. If they come in for a tour, we end up going into the plan. And so one of our benefits advisors, Gibson, brought them in for a tour. It took about 12 months because of when their plan came up, and they also left Anthem and went to United. But they put us in the plan as of 1/1 of this year. And so this kind of tells you what they look like. They are a union shop, rich PPO plan, and so
they don't have the high deductible.
just PPO. So we love that, and they've just been a great partner. And so one of the reasons why I like to talk about them is because it's great to be put into the plan, right? But you need folks in the plan to actually adopt it. And so they put their money where their mouth's at, and they partnered with Marathon Health to put clinics in. And so Marathon has been informed, to let them, if the patient needs surgery, to let them know that. So that's very, very helpful. On top of that, they also hired Quantum for navigation. So Quantum is also talking about us as well. And then something that's simple, but I think is definitely working, is they did a direct mail campaign. They've done 2 of them now. Directly to the homes to get that in the mailbox and hopefully in the hands of the wife, of the family who's driving the healthcare, and make sure that she knows what's going on and that it's actually free to come to WellBridge. So very, very simple, but they've done all of the right steps and zero tier obviously, and because of that, you can see up here, and I'm going to turn it back over to Eric because he put this together, but they're seeing results right out of the gate in the first 2 months.
So this is in the first couple months, just some examples of procedures that happened at WellBridge that, otherwise we got so they're with UHC, the UMR, so we obtained UMR's average event cost, so the average bundle, and that's a huge hurdle as well. People do not know how to make bundles, or they don't want to make bundles. I think they just talked about it in the session prior to this. I don't know what it is. It's either they don't want to or they can't. I think it's maybe both. But this is the best data we have. So to project, okay, this is how much a UMR on average is going to have, within their network discount. This is the plan allowable. And so the savings on the right-hand column, showing for each of these procedures, this is how much you saved, and then the aggregate being a little under $28,000. Another slide that we have, we're trying to cut down the slides. I became a little bit self-conscious. The prior, was it Tim? Is that right? I was like, oh, thank goodness we only have like 6 slides, because if we had 40, we'd be, I'd feel really bad. Another one of the slides, I've actually got the ROIs, the return on investment. So for this actual plan, it's just PPO, and it's an $800 deductible, and there's, so what they do is, I don't think they even have any co-insurance. They have no co-insurance, just an $800 deductible. So not a huge deductible, pretty good plan, especially without any co-insurance. So the most they're going to be paying out of pocket, max out of pocket per year is $800. And I think that's, but so I wanted to tell you the $800 because you got $800 times how many procedures are there on here? Is there 8? I think so. $6,400 is their investment. That's what the company is actually paying, more than what that's an extra expense that they're paying. What they're saving is it comes out to, if you do the math, it comes out to 235% ROI on that $6,400 investment. And it's only $800, and so you wonder, you don't think, oh, I'm not going to drive 45 minutes down from Kokomo to Indianapolis to have my procedure done. It's just going to save me $800. You think maybe that's not a decision people make. Well, they're making it, and they're talking to each other, and they're thinking it's a good idea. So, this is on the lower end, I would say, when we try to make a win-win-win. So a win for the plan, or the self-funded employer, a win for the patient, and it's also a win for the provider, us, the surgeon. Try to make that win-win-win. $800 win is creating steerage from this company that's about 45 minutes to an hour away, and with a 235% ROI for the self-funded employer. And so we'll like to talk about that and say, because when we're talking about zero tier, you're talking to the HR usually. You talk to the CFO about all this, and it makes great sense. But you have to say it does make sense because of the great savings, the high dollar savings. It does make sense to put that investment in, to waive that co-insurance, to waive that deductible. It has to all make sense, and that has to all happen to actually create steerage. And that's something that, like Jeff said, when Keith and Jay came up, Keith was sitting by my right, and I still remember exactly what he said. I said, Keith, what is the threshold that you have to get to actually create steerage to get people to come and make that decision? Because in the end, it is their decision, it should be their decision. But you have to make it a win-win. And he said that it's just nothing out of pocket. Nothing out of pocket, that's the trick. And that's what we found as well. So that's what we want to pass on to people, just to understand what do you need to do that. Another hurdle that we come across, especially in Indiana, the employers there are kind of fixated on percent CMS. And I remember the first time, this is again another Keith, because Keith is, like Sean said earlier, Keith has been instrumental in helping us set up and guiding us along the process. I remember asking him about percentage CMS and what percentage of Medicare, and you remember what he said? He said, which Medicare are you talking about, right? And that's exactly right, because it's several different variables. And so the best we came up with, so we always get that question, and I don't want to answer it because I don't trust. Again, it's tough to say. We want to compare apples to apples because that's when we win, because we know that our apples are better than their apples. But if you're trying to compare, a CMS that the denominator that we come up with versus a false denominator that the competition or the other person's coming up with, you can't trust that. So in the end, we were forced to basically come up with, okay, this is percentage-based CMS, give our references and where we got it. This is just so we are not reference-based, so we do not have just a flat, okay, we're 140% of Medicare, 200% we don't do it that way. We're, the way Keith made prices, we build them from the ground up. That's how, we see how much does it cost to pay a great surgeon a premium to do the procedure there. And then, just the other costs along the way. And then in the end, the right-hand column, this is just what it ends up being is percentage-based CMS.
It's cut, I think it's cut off, what is it, 137?
Oh yeah, I think it is cut off.
The average.
137%.
137%. So we have to talk about it, because that's been a big hurdle for me as well until Eric put this together. But that basically stops the conversation in Indiana, at least, when you can throw that out. So in a good way, stops it.
So another thing we agree with Sean, talking about never events is not something that should ever happen. We ever plan to happen, but that's what everybody else compares. So these are our metrics that we put out and talk to people about, really by necessity. But quality is something that we feel like is, when Jeff said that people come up with any excuse not to change, we feel like the first thing they say is quality, even though they don't know what that means. And they don't know what quality they're comparing that to because they don't know where they were going to go otherwise. But they want to say quality just because now you got an excuse that you don't have to change, you can just renew, and then you don't have to think about it for another year. So that's one of the things we come up against. Our process is, pretty simple. Patient calls in. It's more of a concierge thing with, that speaks to quality as well, but we have a navigator and we specifically put that patient with a specific ENT, somebody who does more ear stuff, somebody who does throat stuff. We try to really take every patient individually into account their diagnosis and pair it with a surgeon who does the most of these that I think that Dr. Panicki thinks would do the best at that procedure. And it goes you can just follow that along. Want to leave some time for questions. It says 0 minutes here left, but wanted to just put this up here. Our staff that we have at WellBridge is handpicked people that we worked with over the last 10 years, and they, when they bring up a concern or bring up something they think needs to be changed or comments, we know that we can trust them because they take very high ownership in their jobs, and from CSTs to the sterilization room to the pre-op nurses to the circulators. We put this stuff up in our break room just to reinforce what they're doing because it's patients notice it for sure. But I would like to open it up for questions and see if you guys have any questions or comments or anything like that. What you got, Dave?
I stick with the best index of all, cash.
Yes,
Yeah.
bingo. Bingo. Yeah, I forgot to mention too, we've only had one selling season because of opening December of 2021. We kind of missed that whole 2021 selling season. So 2022 was our first 1/1 renewal kind of time. So we're probably up to about 55 Indiana-based companies that have that have tiered us basically. And then we've got a good handful of 5/1, 6/1s coming in as well. So I forgot to mention that earlier.
Question over here.
Yes.
So with the out-of-town people, like you mentioned Kokomo, so it's not just the surgery, but the pre-op consultation is now out of town too, right? How are you handling that? Are you making that easier for them?
Are we making that what? I'm sorry?
Or how are you, are they having to drive twice? Is there a way you're facilitating out-of-town consultation?
Yeah, so the consultations are generally done in the surgeon's office, not at WellBridge, but in the surgeon's office where they generally see all the other patients because no surgeons just come to WellBridge. They work at all the different hospital systems around. But people I think are a lot more comfortable with it now, and so are surgeons after COVID. That a virtual consultation or a phone consultation is oftentimes adequate. A lot of and what we do is we leave that entirely up to both. If that's okay with the patient and the surgeon, that's fine with us. We're not going to make that determination. But I'd say more often than not, a virtual consultation is fine, assuming that the patient records, the imaging, all that sort of thing is able to be communicated to the surgeon, and they can make a decision based on that. Certain things like a lot of orthopedic consults, they want to see them in person, want to do an exam, and if that's a deal breaker, it's a deal breaker. But more often than not, it's we try to be flexible with that, but works out. But I would say for most of the procedures, a virtual consultation is adequate, as well as the post-operative consultation.
Any other questions? Yes. Oh, we know that guy.
What is it?
Craig.
Thanks. Greg Edwards, Indianapolis, Indiana. I love these guys. I'm a patient, I'm a supporter, I'm a promoter. I'm curious with the recent non-compete legislation that's been put for physicians, that's been put in the legislature, even though it's not been completely successful. What kind of environment is it to attract surgeons to come to WellBridge and perform procedures when they are associated with other hospital systems?
If they're employed by a hospital system, so far it's proven to be very difficult to get a surgeon to come. We had a group that we know very well, with Dr. Panicki and myself worked with them for years. We like them, they like us. They would like to do procedures at WellBridge Surgical, but it's even gotten to the point where they've hired counsel and talked about their contract and asked the hospital if they were allowed to do that, and the hospital said no. Not surprising to us because the hospitals, with their how protective they are, they're like an overprotective, it's like an over jealous boyfriend. That's what they're like. Like it's, they say you steal patients from them. We'll get an email from the hospital CEO of one of the smaller hospitals and accuse us of stealing patients. It's like you kidnapped one of their kids out of the backyard and had them swim set or something. They're nuts. So they don't like what we're doing. They're very protective of those surgeons. So I hope, and I think right now it's gotten to the point where I think it's primary care physicians would be the ones that they're not gonna have to deal with the non-compete. I know that it would help us. I think that will help us, but I think it would help us a lot more if there was a non-compete with the specialists as well as surgeons. They want to, but with the way those contracts are written, they're not allowed to.
We love you too, Greg, by the way. Thanks for your support.
Anybody else? All right. Well, thank you.
Thanks, everyone.
Appreciate it.
Yep.